Hello, everyone. Thank you for joining us this afternoon. We have Dr. Jeanne Marrazzo. She is the Director of the Division of Infectious Diseases here at UAB with us. She's going to be able to cover a lot of topics related to COVID today. I know there's a lot in the news, but specifically she's here to address some concerns surrounding the Labor Day holiday weekend, heading into that, and how we can have a safe weekend without hopefully seeing cases spike. We will open it up for a Q&A here after her opening remarks. And with that, I will let Dr. Marrazzo come up.
Thank you, Savannah. Hi, everybody. Happy to be here to talk to you on this Thursday before yet another long holiday weekend. Part of the reason we wanted to talk today is that we have, I think, a sense of anxiety and deja vu going into these long 3-day weekends because the last several, including Memorial Day, the 4th of July in particular, have been associated with post-holiday surges, first in the number of cases that we start to see in that 7-day period, and then, of course, with the number of hospitalizations and ultimately deaths, typically in that 14-day period on. So we are really concerned that despite the fact that we are all really tired of this, to say the least, in fact, we are entering what some people might call the most boring part of this, day 2, the middle passage, whatever metaphor you want to use. It's the part where we're just sort of slogging through. We don't really have any new tools yet to control this pandemic. We're still using the same blunt tools of social distancing, wearing a mask, and washing your hands, or the hygiene part, to actually do what we know works to prevent transmission. And we do know that those 3 things, particularly mask wearing, based on now some really nice assessments that have been accumulating since the last time we talked here, that masks really do work, as does social distancing. So really important considerations. So I think the main message really that we want to leave you with today is that there's no time to let up, or this is not a time to let up. We are seeing some positive trends, and those include a stabilization to a decline in the number of hospitalizations, even here at UAB. I think the last time that we had a press conference, or recently, we were in the triple digits for confirmed COVID hospitalizations. We're now down in the range of 50, so that's a very, very big advance. There are also some counties that had managed and appear to maybe be continuing to be down that prevalence, down below that level of positivity or prevalence that we like to see, which is less than 5%, and that's really encouraging. That said, we're still seeing a lot of cases. So in Alabama, we saw almost 10,000 cases this week. If you look at the daily case counts across the country, they still remain between 30 and 45,000 people. And the deaths are not really going away, and they're not declining in all states. There are a handful of states, about 6 to 8, that still have increasing case counts and increasing deaths. So I really want to impress upon people that while we have made some strides with a lot of sacrifice, we are still in a place where we have a lot to do, not only to keep driving things down, but equally importantly and almost more critically to prevent that post-holiday surge that we can almost predict will happen if people do what they tend to do on a 3-day weekend, which is, as I mentioned, coming up. The other thing I would say is the other part of this is that, of course, Labor Day for many of us is almost like the new year, right? You know, you get back to work seriously, you get back to new hours, the kids are back at school, the days start to get cooler, you start to do more indoor stuff. All of those things could really impair our ability to rigorously social distance, also really make us sick of wearing masks, particularly if we're indoors, and equally important, it starts to usher us into the fall and winter respiratory virus, i.e. influenza season. So big concern is that we are going to start to see the introduction of influenza in particular. We don't know when that happens. Typically the uptick starts to occur in October and into November. Sometimes it's later. But really, really critical that we be in the best position possible with COVID before we start to get into the influenza season, and really critical to get your flu vaccine as soon as you can. A couple of other things I want to mention with regard to the post-Labor Day time frame. Mentioned going back to school, we've already seen some impressive outbreaks, particularly in universities across the country and indeed in Alabama. A lot of people have been discussing vigorously what the best way to handle these outbreaks is or are. Should we just shut the schools down? Should we send children or kids, students back to their home communities and just call it a day and maybe come back in January when things are settled? That's a really interesting and important question, and I think it has a lot of dependent variables. But in general, if you have an outbreak on a campus, university campus, and you have the capacity to maintain some semblance of comfort and order, safety and security, and education virtually for the students on that campus, it actually makes sense probably to keep those students on campus. And part of the reason for that is not only that it gives you more control, more ability to chart what's happening to those students, not just from their own personal health perspective, but from the propagation of the epidemic or the outbreak in that context. It also really, really critically keeps them from returning to vulnerable communities and reintroducing the chain of transmission into those other places. And that's going to be especially difficult if those communities have already made great strides in controlling COVID. And as you know, there are a lot of places now, particularly in the Northeast, that have done a great job getting down to what are very low levels of community positivity and infections. And so you really don't want to sort of send these students back into those communities where they may also not be rigorously practicing the kinds of methods that I mentioned, and then making their contacts vulnerable. There's a very number of really disturbing stories in the press the last couple of weeks of places that really didn't have much. Maine is a great example. There was a big wedding there, and those wedding guests ended up infecting a whole series of people, including an elderly woman who had never left her home and died because she was exposed to people who had come from that wedding. So we want to avoid those tragic events. We want to avoid the public health challenge of introducing the infections back and getting those economies back off track. And then we also want to try to take care of students from an educational and a health standpoint in the places that they're staying. So I think those are my main messages. One more thing I would say is, if you look at the modeling that people are doing based on what we have seen from previous 3-day weekends, so let's say what happens after Memorial Day, or what happens even more concerningly after July 4th weekend happens after Labor Day, then we are in for a not good scenario in September and early October. It basically means that our hospitalization rates, probably our death rates, are going to climb way back up to the levels that we saw in July. So it's really important, because we narrowly escaped a serious crisis with hospital capacity and ICU capacity, as you all know, in July and early August, just narrowly. It's really important that we do not revisit that situation. And the only way we can do that is to keep hanging on with our agreed, boring, painful, old measures of social distancing, wearing your mask, and washing your hands. So I wish that I had better news. I will share one piece of good news that I know people were interested in talking about, and that's the recent data that came out, I think the day before yesterday, it may have been yesterday, in the JAMA, which concerned several studies looking at steroids and their treatment for COVID. Really good news in that the use of steroids in several studies, and then in a big analysis of a bunch of smaller studies, showed that people who were severely ill and hospitalized, very important caveat, had a reduced mortality by about 1/3 when steroids were used. That's great news. It's similar to what the recovery trial from the United Kingdom showed us a few months ago, and that's what made everybody get on board with steroids, and it also changed many of our guidelines where we actually are using steroids. The caveats, I think, are that the people in those studies were critically ill. For example, in one study, they had to have adult respiratory distress syndrome, or ARDS, meaning they were intubated and really having trouble oxygenating their lungs. So we don't know yet how it's going to perform again in people with mild illness. And the other huge group we are still struggling with are people who are in the clinic, either with newly diagnosed COVID or COVID that just has taken them out for several weeks. And I want to emphasize that just because you're young, you may not get a pass on this. You know, you may not die because you're a 20-year-old healthy person, although it's not out of the question. But we are absolutely seeing, and we are hearing reports of young people who are really physically limited weeks, even months after their COVID infection. So be aware, this is no picnic for anybody, and really nobody gets a pass except those people who are lucky enough to have asymptomatic infection. But even they, remember, are capable of transmitting the infection to other vulnerable people. The last thing I'll just mention before I take questions is, remember, we've heard a little bit in the last couple of weeks now about the possibility of reinfection. So a very persuasive case last week published from, I think, Las Vegas, where they had a young man who quite convincingly had 2 different strains of the virus several months apart. And they know that because they looked at the genetic sequence of that virus. So should we be concerned about that? It's definitely something to keep in the back of our minds. What we tell people who have had COVID when they ask us if they can get reinfected is that, yes, it's a theoretical possibility. It probably doesn't happen in most people, but we just don't know yet, and we recommend that you continue to use the same precautions that everybody else is using. In other words, just because you've had COVID doesn't mean you can assume you're immune. And that's a really hard, not welcome piece of news. And hopefully we'll understand more about it as we understand more about the immunology of this infection. I think I will stop there and go ahead and start taking people's questions.
Fantastic. Thank you so much, Dr. Marrazzo. And just a few housekeeping items before I go into Q&A. We haven't done a news briefing like this in quite some time. This is live on Facebook. You cannot see anything right now on the computer, or you would see me. So we will send out a recording of this after the fact as well. If you've got a question, please raise your hand or drop it into the chat. But let's go with raising our hands first. And so if someone has a question they'd like to start with, we can kick it off. Jeff Eliasoff, feel free to ask your question. All right, I think you're muted.
Okay, how about, am I unmuted now?
Yes.
Good, I appear to be showing up in Channel 6's view box. So that's my first question. How do I get over there? Okay, there we go. My question, of course, would be about a vaccine. And November 1st, all of a sudden, when we were hearing that nothing was going to be remotely possible from Dr. Fauci until sometime next year, what should Alabama be doing to prepare for such an event if such a thing is possible? And is it possible now, all of a sudden, leaving the politics of it aside, is it possible to have a vaccine ready for wide use on November 1st?
Jeff, that's a great question, and I was sure someone was going to ask it. It's a really complex answer, which I will try to break down quickly so that we don't spend a half an hour talking about this, because we really could. So back when we were talking about the projected timeline for a vaccine, Dr. Fauci, most experts emphasized that the way clinical trials were conducted were that you would enroll a whole bunch of people first in those phase 1 safety vaccines, which we now, phase 1 safety trials, which we now know there have been a number that look good. So we are actually through a number of those phase 1 trials, moving quickly into phase 3 trials, and phase 3 are called efficacy trials. That's where you figure out, does the vaccine work, okay? At that point, the best case scenario that we were talking about was maybe available next spring or next June. And the reason for that was we know that, for example, the Moderna vaccine study is now, I think, almost 2/3 enrolled, if not more, of its 30,000 participants, right? So you're going to follow those people who either got the vaccine or a placebo product over the course of the next several months to see what happens. That study has been powered to look at the incidence of coronavirus disease in people who got that vaccine. And if you use that as a marker, the best case scenario, I think, especially in areas that still have a lot of coronavirus, which is not the whole country anymore, probably you might get a signal sometime in early 2021. And I think that that's what people were thinking about. And maybe a signal of efficacy would be so great that the monitoring boards for the study would say in February, stop the presses, because this looks so good, we can't even continue to study it anymore. And you can imagine then ramping up and getting it out. Now what we're hearing is that the availability of a vaccine sooner might hinge on two things. One is that there are European data, particularly for a couple of vaccines, UK data, and that the FDA should potentially consider whether those data are enough to assume that there are efficacy. And I need to refer back to the previous question because I forgot to mention the second measure of efficacy. So the first is the number of cases. The second are markers of immune reaction to the virus. So that means you get the vaccine, 4 weeks later, they take some of your blood and they say, are you making the antibodies that we think will protect you from the virus? And really for the Oxford vaccine in particular, the UK vaccine, Astrazeneca vaccine, that's the evidence we have. And that's the evidence that we have for all the vaccines. We have no evidence that it's going to reduce the number of cases. So let's go back to what we're hearing now. We're hearing now the two things. First, as I said, that the UK data in particular for this single vaccine and maybe even other European data is enough. The second piece of this is that, maybe we don't need to prove that an effective vaccine reduces the number of actual infections in people. Maybe we can just say that it induces protective antibodies in people. And if that's the case, let's just approve it on the basis of protective antibodies and get it out there because we need to. So what are my concerns with this? And there's a great perspective article, again in JAMA, that I would love to share with you all. If you tweet me, I'll put it on my Twitter feed. And it's very accessible, but it talks about the concerns with getting a vaccine out too fast. And I would say there are several. First of all, we don't know enough yet about what real immunity, long-lasting, robust immunity to the coronavirus is. I mentioned before the person who got reinfected. How do we know that that's not going to be a risk with whatever vaccine we use? Okay, so I think some people would probably disagree with me and would say, oh, we can measure really sophisticated kinds of antibodies, and if I saw that response, I'd be comfortable getting that vaccine. That may be, but it is a definite data-free zone or data-arguable zone, and it's a risk. The second is we have never used a messenger RNA vaccine in a human population before these trials. This is a totally new technology. We think it's safe, but we don't know. It's not a tried and true method. And so that, for me, really increases the bar for safety a lot, okay? The third thing is that problems that come with vaccines can be rare events, but they can be devastating. And that's why we have vaccine registries, and it's why we are super, super careful in the phase 3 studies to follow people carefully, at least for a year, if not longer. What's a good example of when that was not done? Many of you are probably too young to remember. I barely remember it myself, but swine flu. Swine flu was a perfect example. 1976, there was an outbreak in Fort Dix, New Jersey, among soldiers there. They got something called swine flu. They got really sick, and there was a general worry that this was going to be a virus that was very similar to the 1918 flu epidemic virus. There was a lot of discussion about what to do, and President Ford at the time basically gave the green light to go ahead and widely administer a vaccine that had not really been adequately studied because of the threat of this quote-unquote possible pandemic. 45 million people got that vaccine, a couple died, and 450 of them got Guillain-Barré syndrome, which is a neurologic disease that can result in death and respiratory failure. And we know that that is a risk factor with that vaccine. It's discussed in this JAMA paper, but it's a real cautionary tale of how, and who knows what the calculus was at that time. I mean, it was a valid concern, but there were many people who thought that was ill-advised and it was rushed. My big concern about this timeline that's now out there is that not only do we not have the kind of evidence for efficacy yet, I'm saying yet, maybe they know something I don't know, it's always possible, but do we really have confidence that we can go out there and vaccinate everybody safely without knowing the longer term benefits or side effects of this vaccine? That's my really big concern. And then that's, remember, happening on a background where Americans are among some of the most vaccine hesitant populations in the world, right? There are pockets of the United States where people aren't going to even get a killed flu vaccine, which we know is absolutely safe, or a pneumonia vaccine, or a shingles vaccine, or whatever, or measles vaccine, right? So, you know, people have been incredibly concerned about vaccine safety for decades, and we've spent countless hours, countless press conferences, countless meetings trying to assure them that we have done our absolute best to make sure that every vaccine we give is safe. And that's why it's okay to give to your children, right? This is not that. This is exactly the opposite of that. So it makes me very concerned. Again, maybe there's an unbelievable scientific breakthrough that I'm not aware of that makes the people who are pushing this confident of saying this, and that's always possible. But knowing what I know, and I would say knowing what most infectious disease, your average kind of academic and practicing infectious disease physician knows, I think this is a very concerning trend. So long answer, but really important for you as the excellent media spokespeople you are to understand the intricacies of how these decisions are made and what the consequences are.
Thank you for that answer, and I think that everyone on this call would agree that that is beyond helpful context. We're going to go with Henry Thornton with Yellowhammer News, and then we'll go to Miranda with WBHM. So Henry, feel free to ask your question.
Hi, Dr. Marrazzo. Thank you, as always, for being here with us today. My question is about a certain categorization issue with the new case numbers we're seeing come in. So essentially, the Alabama Department of Public Health is putting, and I'm sure everyone on this call, and you probably more than us, have read about this already, but they're putting people who've been tested with the antigen tests or the rapid tests in a category called probable cases. I was hoping to solicit your thoughts about whether that sort of properly communicates how likely someone tested via a rapid test is to actually have a case of COVID-19, and any advice you can give us in the media for how to properly or to communicate those results would be very helpful.
Yeah, Henry, this is something that's been keeping me up at night for the last several weeks as I've been thinking about what the advent of these new tests is going to do to surveillance, and I'm afraid that all of my nightmares are basically happening. So it's really complex because, first of all, not all of these tests are created equal. And going back to the FDA, one of the challenges with the FDA's recent behavior has been that they've granted emergency authorization, use authorization, to so many tests that we really don't have a clear handle on what their performance characteristics are. That's one of the reasons that responsible reporters like departments of public health are listing those infections as positive, because technically right now, if you get a non-PCR test, a non-polymerase chain reaction test, you're supposed to confirm it with PCR to actually make sure that it's a confirmed case. Now that's not feasible, number one. Number two, it defeats the purpose, right, of having these rapid, easy to do, accessible tests. So at some point, you've got to decide, is the test being used for surveillance so that you can get better assessment of what the case trends are in a given place? Or are they really best used as diagnostic tools when you're evaluating the patient who's sitting in front of you? I would say that the tests are really designed for the latter purpose, right? They're really so you can do tests in somebody who's symptomatic, or maybe test somebody who's been exposed and is a contact. When you get into using them for surveillance, it's really tricky. I'll give you one other example. For example, one of the better antigen tests, which is the Sophia test, has performance characteristics that indicate if you test someone within the first 5 days of their symptoms, you're going to get a positive result like 97% of the time when the patient's actually infected. That's excellent. And if it's a negative test, you can believe that they're really not infected. We don't have any data on how that test performs in somebody without symptoms, and yet it's being used widely for screening. Do I think it's good? Yeah, I do think it's good, because I think you can probably believe the negative test, but we don't know. So the short answer is that I think the probable numbers are reliable from the standpoint of accuracy for positivity. So if you have a probable test by one of these antigen tests, by and large, I think you can believe it. And again, it may be that there's a new antigen test that's going to come out tomorrow that makes me a liar. But in general, I think you can believe it. I would personally rather see those tests on the dashboard in the probable category than see them being missed, which was my concern. My concern was that all these tests were going to come out, people were going to be doing them in the point of care situation or in places that weren't connected to reporting structures, and we weren't even going to see those numbers, and we were going to have a false sense of security as the PCR test reporting came down. So I'm absolutely glad that they're there. It doesn't tell us again with precision how many tests are being done, because that part we don't know. With the PCR tests, we know what that denominator is because they're all done in a laboratory. With the other things, who knows who's doing them? So I would say believe the positives, be skeptical about the number of people that are being tested, and know that the probable designation is really kind of just I think it's more of a formality at this point, because technically you are supposed to confirm them with PCR. I've been frustrated, though, with the recent reporting on ADPH. As you know, there have been a lot of influx of old tests that hadn't been reported. There's now delays in reagents again, so there's delays in testing. So remember, I think charting day-to-day numbers is helpful, but I wouldn't, I wouldn't sort of depend on it. You really have to look at trends, probably ideally over 14 days and over 7 days.
Thank you, and thank you, Henry. We'll go to Miranda with WBHM. You can ask your question.
Hey, okay, thank you so much. Dr. Marrazzo, going back to the topic of a possible vaccine, I'm just curious, since you mentioned that we don't know the long-term, efficacy or effects of even a current phase 3 vaccine like Moderna, I have to wonder, if a vaccine like that did come out, would you get it yourself? I mean, I know that we don't know the long-term effects, so I'm just curious from your point of view, having so much knowledge about this stuff.
Yeah, thanks for that excellent question, Miranda. If I was going to get a vaccine, and first of all, I'm planning on volunteering for a trial, so I think that is a really important thing for us to do, because we're trying to get people into trials, and I feel like it's important. I haven't done it yet, but I'm on the list. If I was really going to get a vaccine, I would want to be really sure of its safety. I mean, again, that's just the way that we're all wired, right? What would that take? That would take my assessment of the database that came out from these studies. So let's just take the Moderna vaccine as an example. In January, what if it looks really good? Well, the first time a Moderna vaccine was ever put in a person was last March, okay? That means you're potentially thinking about licensing and distributing a vaccine to millions of people that has been in this world for less than a year. It's really a risk-benefit balance at that point, right? There are so many people who remain vulnerable to this infection because they can't social distance, maybe they can't mask, and maybe there are other issues. Maybe they have immunocompromise that puts them at a very high risk of complications if they get infected. Someone in those situations could say, this looks okay, it looks good, it's been out a year, I think it's very reasonable. Other people, like me, might say, I've done okay so far doing my boring masking, hygiene, and social distancing. I'm going to keep doing that until I see how this evolves over the course of the coming months. Now, is that something I have to think about a lot? Because what if something changes in the next month? What if we find another consequence of COVID infection? What if we find out that reinfection is the rule rather than the exception? We don't know. But at this very moment, I would say I would probably not get it. That said, if there was full-throated endorsement from something like the American College of Immunization Practices, the ACIP, and there was a great database and people felt like it was awesome, then I would consider it. But I'm inherently cautious about this. I guess the other thing to say is that, just when we put new drugs on the market, sometimes they look great in phase 3 for safety, and then you put them on the market, and when they get into millions of people, you start to see the rare but consistent side effects. So we have to be very, very vigilant about that.
Thank you, Miranda. Thank you, Dr. Marrazzo. Morgan with Fox 6, feel free to ask your question.
Thank you, Savannah. Dr. Marrazzo, I'm just curious about how African Americans are disproportionately impacted by this virus. And in terms of a vaccine, there's a lot of conversation happening nationwide that there's not enough diversity in the enrollment that has already happened. Can you tell me first if at UAB, y'all are having issues enrolling a diverse population of people for these trials? And then secondly, can you tell me about why it is so important to have this representation in the trial to make sure that the vaccine is working appropriately for everyone?
Yeah, great questions, Miranda. Thank you for those. So first of all, we have not started a vaccine study yet at UAB. We will be, we hope, starting the Astrazeneca vaccine study in the coming weeks. And when we do that, you will be the first group to know about it because you've been loyally following us for so long on this topic. That said, we are already mobilizing to be sure that we reach out and try to pull in as diverse a population as we can get. And not just diversity, but also, I think it's really important to enroll people who are the most vulnerable and who are likely not only to suffer the most from this infection, but who are likely to benefit from the vaccine the most. And you mentioned African American people. There is no question about the disproportionate percentage of deaths that these people, as African Americans, Black Americans, are experiencing. And absolutely, that would be a principal focus for us to enroll. So one advantage that we have here is that we have an Alabama vaccine research clinic that's led by Dr. Paul Gepfert. Many of you know Paul. He's worked a lot on influenza vaccines as well as HIV vaccines. And so this group, our group, has a lot of experience of reaching out to people who are more vulnerable, from whatever reason that might be, socioeconomic standards, maybe there are elderly people, all kinds of things that increase people's risk of getting those kinds of infections. So, so we are teed up, and we already have community outreach folks who are trying to make sure we have a lot of people who are ready to enroll. It's been a big challenge with the Moderna study, and I'm sure you've heard some of that press. Sometimes the first people who line up for these studies are the people who have the best access to and best information about medical care, of course. And while those people are critically important to study as well and to get the benefits as well, really, really have to pay attention to who really needs to benefit from a vaccine type intervention. So thanks for that question.
Thank you, Morgan. Does anybody have a question that they'd like to ask? We are going to try and wrap around 2 o'clock, just in the interest of time. So if you've got a question, okay. Jeff Eliasoff, feel free to ask your question.
Muted. Okay. Dr. Marrazzo, again, many thanks. I come from a family of doctors. I wasn't smart enough to be one, but your explanations of complicated things are wonderful for viewers. And I think we get a great benefit out of that. for our folks. On the question of numbers at UAB itself right now, I know there are day-to-day differences here, but they seem to be down. Give some context about why that may be happening here, and I guess restate your fear of what may be coming here over Labor Day.
Yeah, thanks, Jeff. That's a great question. I think there are a couple things happening. When you look at, so every day I get a list, because we're trying to get people into research studies in particular, every day I get a list of people who are admitted, who are discharged, and who are designated as convalescent or recovered. The list of people admitted has dramatically come down. I mean, we were really very high in July, which gets to the second part of your question. This is where we're going to be if Labor Day is not taken seriously. So really very high. And then the list of discharged people was really very small. We're now seeing a much more equal distribution. And I think what's happening is that not only are we seeing fewer cases coming into the hospital from the community in terms of admissions, because people have been largely adhering, particularly in Birmingham, to the social distancing, mask wearing directives, which is fantastic. But also, we've been, I think, reducing the length of stay of folks. We've gotten better at certain measures to take care of people. I would say the biggest things being more availability of remdesivir, routine use of steroids, and much interestingly, more sort of vigorous approaches to the way we handle intubated patients, which includes proning, turning them over to make sure that all of their lungs get good oxygen penetration. So, and if you look at our mortality rates, unfortunately, they're not zero, but they're really good compared to many other centers. So we've been seeing fewer patients admitted. The people who are admitted, we've been trying very hard to keep out of the unit. The other thing I should mention is that we learned quickly not to put people on the ventilators very soon, as did many other people. We learned that from our colleagues in New York and Seattle, because our initial instinct was immediately to put people on a ventilator. And it turns out that with this weird disease, if you can keep them off a ventilator and just give them high flow oxygen through a nasal cannula and get them through that early period, they do much better. It's really interesting. So we've been doing that a lot more. I mentioned the way we're handling proning, and then there's also the steroids. So I think we have learned an incredible amount in the last several months about how to take care of people, and I think that's kind of gotten our folks out and discharged quicker. So all of that has taken all of the work that everybody's done, and I think your question about Labor Day just brings me back to, please don't make all that for naught. Because if we start to fill up again, we start to see the hospital being broken down by COVID, we can't continue to give people care for the things that we need to give them care for, and we'll just start the cycle again of exhaustion, demoralization, and probably less of an ability to give people as much care as they really need. So it's definitely linked, and I appreciate you bringing that up.
Thanks, Jeff.
Yeah, if I could just follow up real quick on the vaccine. During this last half hour, I've had occasion to speak to the governor's office, and I really didn't get anything out of them other than we're studying this with the experts, this getting ready by November 1st business. Well, I know that the governor has enormous respect for you in particular and UAB. So I guess give me a couple of headlines or sound bites about what you would tell her about November 1st, in light of the fact that you are not satisfied that we're ready to go unless you say somebody out in the world knows something you don't. We're not really ready on November 1st to give somebody a 100% safe, effective vaccine.
Right. Now, remember, the governor is also responding, however, to the directive of the CDC. So the CDC director, Dr. Redfield, was the person who wrote that letter that came out yesterday telling states that they should prepare. Now, again, Dr. Redfield has a lot more inside information than I do. Maybe he knows something that he's communicating, or maybe they're really trying to get ahead of the curve and they want people to gear up so that anything can be available as quickly as possible. I mean, the headline is hard because you saw how long it took me to answer the question. I think the main message is that we need ironclad proof and assurance, to the extent that anybody can get it in any vaccine study or any medical study, that whatever product we make widely available to our citizens is as safe and effective as is humanly possible. We are not, at this very moment, on September 4th, whatever day it is, 3rd, 4th, we are not there right now. There's no way that I have seen myself, and I know that most experts have seen enough data to feel like not only today there's something to roll out, but in 7 short weeks, I believe that would be, that there would be, 7 short weeks, right? That there would be something to roll out. So the message to me should be, we deserve the best. Yes, I know there's urgency, but we can manage this with admittedly the tiresome, difficult, boring things that we have talked about. And that's not to say we don't urgently, emergently need a vaccine. We do. But we should not sacrifice our convenience for the rush to get a product that we just don't know is really, truly safe to get to people. And we deserve the best. We deserve better. I mean, people have been through hell with this thing.
All right, we are at that 2 o'clock mark, so we're going to just take Miranda's question from WVHM. She's had her hand raised a while, and then we will conclude. So Miranda, you can ask your question.
Okay, great. Thanks, Savannah. And I'll make it super quick. And Dr. Marrazzo, you may have an answer to this, you may not, but I'm sure as the conversation continues to progress about vaccines, people will have questions about pairing a possible COVID-19 vaccine in addition to getting their flu vaccine. As someone that's not overly familiar with vaccines and how or whether they could react to one another, is it possible for vaccines to react with one another? Like, would people be safe in general, or we just don't know enough about it right now?
That's a fantastic question. Of course, we don't know enough about it by now because, as I mentioned, these mRNA vaccines and protein vaccines, I should mention too, we can talk at another point about the difference, but all of the technologies that are being used for these new SARS-CoV-2 vaccines are not in any circulation right now in terms of available vaccines. We don't know enough about that in combination with something like the flu vaccine. I will say, though, in general, when you're talking about vaccines that don't involve a live virus, like the pneumonia vaccine, the flu vaccine, you can give them together without a problem. Kids get vaccines. They're the classic candidate, right? The poor things, they're often like little pincushions when they come out of the pediatrician's office. The flu vaccine in particular is really interesting. You probably don't need to worry about that. And in fact, the studies that are being done have explicitly incorporated a protocol to manage administration of the flu vaccine within that study, because it would be unethical, right, to withhold a flu vaccine in people who are participating in COVID vaccine trials going into the influenza season. I don't know what the exact timing is. My guess is that it probably has to be separated by at least 2 weeks to 30 days, but we can check on that. But you probably aren't going to get them together in a study, but you can definitely get the flu vaccine this year and participate in a research study or get a vaccine if it does come out and we believe it's safe.
Thank you.
Fantastic. Thank you, Dr. Marrazzo, and I'll come up and give some final comments.
Thanks, everybody.
That is going to conclude our news briefing for today. I will send a recording of this out hopefully in the next hour or so. Will give us some time, just a little bit patient. If you have any other questions, feel free to email me and we can try and get those answered. Again, we cannot stress enough to please be safe, wash your hands, social distance, and wear masks. Wear them correctly this weekend when you're with friends and family celebrating Labor Day. That will conclude our news briefing today.